So it is right at noon, so we will get started. Good afternoon, everyone. My name is Olivia Hensey from the New England QIN-QIO, and I'll be your moderator for today's webinar, Review of the Transition Record with Specified Elements for the IPFQR program. The Quality Innovation Network Quality Improvement Organization works with healthcare providers, stakeholders, and communities across New England on data-driven quality initiatives to improve patient safety, engage patients and families, and improve clinical care at the community level. Thanks for joining us today, and before we get started, just a few housekeeping items. This call will be recorded for training purposes. I'll provide you with details on accessing the recording at the end of this webinar. The phone lines will be on mute for the duration of the presentation, and we'll take questions at the end, and I'll provide you instructions on how you can ask a question over the phone, or at any time you can pose a question in the chat box. Just make sure that you're sending to all participants. So at this time, I'm going to pass it over to Jean Dufresne from the New England QIN-QIO, who's going to get us started and introduce our presenter. Jean?
Thank you, Olivia. Charles Alexandre has been a registered nurse for over 30 years. He graduated from Rhode Island College with a BS in nursing, the University of Rhode Island with an MS in nursing administration, and he completed his PhD in nursing and health policy at the University of Massachusetts, Boston. He has been a staff nurse, nurse educator, and nurse manager in inpatient settings, hospice, and home care. He is the former state director of nurse registration and nursing education and chief of health professions regulations for the Rhode Island Department of Health, and is currently the director of quality and regulation at Butler Hospital in Providence, Rhode Island. The floor is yours, Dr. Alexandre.
Dr. Alexandre, you just have to press pound 6 to unmute yourself. Dr. Alexandre?
Did that do it?
Yeah, we can hear you.
Okay, thanks. Sorry about that.
No problem. Thank you.
Okay, so we're going to talk about implementation of these new measures. So I thought what I would do is just start here.
Okay, mine is no longer speaking. So.
It does look like we have a little bit of background noise. I'm sorry to interrupt, Dr. Alexandre. If everyone could please put their phones on manual, there is sometimes background noise that comes through. Floor is yours, Dr. Alexandre.
Thanks. Great. So the agenda, we're going to spend a little bit of time defining what the transition measures are. We'll discuss the individual elements of the measure, and we'll talk a little bit about some challenges to implementation of the measures, at least from our perspective here at Butler. I'd be interested to hear what other folks, any challenges other people have been having as well. As for our objectives today, so at the conclusion of the presentation, we hope that you would be able to describe the requirements for the IPFQR program transition record measure, define the individual elements of the transition record measure, and describe a plan for implementation of the measure. So these are the two measures we'll be talking about. The first is the transition record with specified elements received by discharged patients, and then the second is the timely transmission of this transition record. So both of these measures were developed by the American Medical Association, and they were also both endorsed by the National Quality Forum. And we began implementing and collecting data for these measures as of January 1st of this year. So the transition record with specified elements, the goal of this measure is to assess the percentage of patients discharged from an inpatient psychiatric facility or their caregivers who receive a copy of this transition record at the time of discharge, and that the record includes all of the specified elements. The rationale, obviously, is that hospital readmissions can be prevented by good, strong patient education, thorough pre-discharge assessment, and appropriate aftercare. So I'll just give a quick run-through of the specified elements, and then we can talk about them in a little more detail. So they're broken up into 4 categories. The first is inpatient care, and for that, the record should contain the reason for the inpatient care, a list of major procedures and tests performed during the inpatient stay, and a summary of the results of those procedures and tests, and principal diagnosis of discharge, The next section is on post-discharge and patient self-management. So it should include a current medication list. It should include any studies or tests that are pending at discharge, and obviously patient instructions. And the advanced care plan, it should talk about, it should have some information on whether or not there is an advanced directive or if a surrogate decision maker has been identified. And that should be documented in the record. And if it's not documented, there needs to be a reason as to why it's not documented, and we can talk about that in a moment as well. And lastly, it's contact information and the plan for follow-up care. So we need to have documentation of some sort of contact information for 24 hours, 7 days a week, including the physician for emergencies related to the inpatient stay, because it is, generally the physician who discharges the patient who maintains responsibility for that patient generally until there is a follow-up appointment. Should include contact information pertaining results of studies pending at discharge. It should include the plan for follow-up care. And again, it should include the name and contact information for the primary care physician or some other healthcare professional or a site designated for follow-up care. So in order to make the measure, all of the 11 elements have to be present. The numerator for the measure is the number of patients or their caregivers who received the transition record and with whom a review of all of the included information was documented at the time of discharge. The denominator, again, is all patients, regardless of age, discharged from the inpatient facility to home or any other site of care. And there are a couple of exclusions from this measure. And they include patients who died while they were an inpatient, patients who left care AMA, or patients who discharged. Discontinued care is defined in this measure as patients who either eloped from the facility or patients who failed to return from PATH. The reason obviously precludes any kind of effective discharge planning if the patient is there.
Dr. Alexandre, I'm sorry to interrupt again. It does sound like we have a little bit of background noise, so again, if you could manually mute your phone, we do hear some background noise. Excuse me. Okay, sorry, Dr. Alexandre.
No problem, thank you. So the first measure is, we'll get into the measures. The first measure is measures timely transmission of the transition record. So again, the goal is to assess the percentage of patients discharged from the inpatient facility to home or any other site of care for whom the transition record was transmitted to the next level of care designated for follow-up within 24 hours of discharge. So the numerator is all of those patients for whom the transition record was transmitted with all 11 elements and within 24 hours of discharge. And the denominator, again, is all patients regardless of age, same as the previous one with exclusion. The record may be transmitted via mail, fax, to your email. It can be transmitted through the electronic health record. A hard copy of the record can be given to the personnel transporting the patient to the receiving facility. For example, ambulance drivers could be given a copy to bring with them. And then it's important that the time and method of transmission should be documented. It's also important to note that if the next level of care is within the hospital or a hospital system that shares a medical record, for example, for us it would be a patient leaving our inpatient unit and going to one of our partial hospital programs, the discharge plan indicate in the record that the next provider has access to the medical record. transmission to count towards the measure.
Dr. Alexander, this is Olivia. If you don't mind me just interrupting for a minute, I'm going to go ahead and unmute and remute the lines for you so that there is no background noise coming through. If you don't mind, I'm going to do that right now.
Okay.
I'll let you know when to press pound 6 to unmute yourself.
Sure.
The leader has unmuted your line. The leader has muted your line. To unmute your line, press pound 6.
Okay, Dr. Alexander, if you want to press pound 6 to unmute yourself, hopefully that will have dealt with the issue.
Okay, did that work?
Yeah, I can hear you. Again, I'm sorry to interrupt. Hopefully there will be no background noise now.
Okay, no problem. That's fine. So we'll talk a little bit about each of the elements of the measure. So first we'll talk about 24-hour, 7-day contact information. So this measure requires that a healthcare team member with access to the medical record and other information related to the inpatient stay be available 24 hours, 7 days a week for the patient. This does not include 800 numbers, crisis lines, or general emergency contact numbers in this measure. So giving sort of a general number for the hospital would not work unless there was very specific information about how to contact someone specifically. Here at Butler, we provide, generally we provide the inpatient unit number because staff, they're 24/7 and they would have access to the information that the patient would be requesting, and they would be able to contact the attending physician for them as well. Contact information for and plan for follow-up care. For patients discharged home, the 11 elements must be shared with the patient and the caregiver. For patients discharged to an inpatient facility, the record can indicate that these 4 specific elements can be discussed between the discharging and the accepting facility. So the 24-hour contact information for obtaining results, plan for follow-up care, and primary physician can be discussed between the 2 facilities if the patient's not going home. So there also needs to be contact for a healthcare professional or facility that the patient can call to receive information about studies not concluded by the time of discharge. Again, we use the same number here that we would to contact the physician. And the types of studies that may be addressed, blood work primarily, any radiologic imaging that may have happened, and that would pretty much be it for us, certainly here at Butler. When we talk about advanced directives and surrogate decision makers, the transition record should indicate whether or not there's a written signed statement that details the patient's preferences for treatment, should the patient be unable to make those decisions for himself or herself due to either psychiatric or medical reasons. The statement should inform others about what treatment the patient would or would not want to receive from psychiatrists or other healthcare professionals concerning, again, both psychiatric and non-psychiatric care. And it must be compliant with state laws in which the patient receives care. The advance directive doesn't, the measure doesn't require that the patient has an advance directive. But there must be a reason documented in the transition record if the patient doesn't have an advance directive or hasn't identified a surrogate decision maker. And it must provide patients with an opportunity to complete an advance directive if none exists. And also a copy of the advance directive does not have to accompany the patient. It just needs to be noted in the record that there is one. There's a couple of very specific reasons why there may not be an advance directive or why one was not provided for them. And you need to document that reason to successfully complete the measure. And so we would document that the advance directive or surrogate decision maker was discussed with the patient, but the patient was not, didn't wish to have one or wasn't able to provide an advance directive or a surrogate decision maker. Or that document that the patient's cultural and or spiritual beliefs preclude such a discussion and would be viewed as harmful to the patient and a physician-patient relationship. Those are the only two acceptable reasons why there wouldn't be an advance directive or surrogate decision maker in the record. So another element in the transition record is the current medication list. And so this list has to include prescription medications, over-the-counter medications, any herbal products the patient may be on. And it needs to include medications that are to be taken by the patient after discharge, and the medications not to be taken by the patient after discharge. Under medications to be taken by the patient, should include medications used by the patient prior to hospitalization that are going to be continued after discharge. It should include any new medications starting during the hospitalization and to be continued after discharge. And also any newly prescribed or recommended medications to be taken after discharge. So the list of medications need to include recommended dosage, any special instructions or consideration, and the intended duration for each medication listed. CMS will accept a blanket statement indicating that routine medication should be taken until told to stop for most medications. Medications not to be taken by the patient. So again, they need to include everything the patient might have been on at one time, prescriptions, over-the-counter, herbal products. Taken by the patient. These are patients taken before the inpatient stay, and they should be discontinued or withheld after discharge. So it's a pretty extensive list of medications that we're going to send home with the patient. We also need to identify any major tests or procedures that may have taken place while the patient was in the hospital, and we should include a summary of results of any of those tests or procedures. And they don't have to be everything, but things that are noteworthy that support the patient's diagnosis and treatment or may affect the discharge plan in any way. So again, some of those examples are mostly complete blood counts, metabolic panels, certainly that may require some sort of follow-up after discharge, any radiologic imaging, and certainly, we would want to include ECT in that. The patient, received ECT while they were here, and whether or not they would continue to receive that on the outpatient basis. Patient instructions. So obviously these are directions for the patient and caregiver to follow upon discharge. They should be appropriate for the patient, and they should include the use of language services as appropriate. Again, it's, medication information, activity restrictions, what to do if symptoms recur, those kind of things. And we need to be able to document somewhere in there that any sort of language service was used, a language line or interpreter or whatever, should be documented in that record as well. We need to document a primary care physician, any healthcare professionals or site of care designated for follow-up. These could include obviously the PCP, a psychiatrist, psychologist, a therapist, any kind of specialist that the patient may be seeing, really any healthcare professional at all. And it may be a site, a community health center or community mental health center or group practice specific to the psychiatric care may also be measured. Again, hotlines or general contact numbers don't generally suffice, and they want specific information about how to contact each of these people. And then any plan for follow-up care. So we should be able to describe the treatment and supportive services that the patient is going to require to maintain or optimize health. according to the patient's goals. Should include dates and times and contact information for any appointment, post-discharge therapy that might be needed, any durable equipment that might be needed, and any outpatient resources that are available to support smoking lines, things like that, for self-care and other instructions. So that's sort of an overview of the measures. I'd like to spend, quite frankly, most of the time talking about how this is implemented and challenges, certainly some of the challenges that we have as implemented. I'd really like to hear any challenges that anyone in the audience might have had in how you overcame some of those challenges and, suggestions for those of us that still are struggling with some pieces of the measure to share some of that information. So obviously, we started this by doing a gap analysis. Now we did this well over a year ago. This measure was supposed to have started last year, and then it got extended, it got postponed a bit to January this year. So we had to look at our electronic medical records for the required data elements. We had to map the data elements to a discharge report. So we had all of these things, but certainly our patient care instructions didn't necessarily include everything that's included in this measure. One of the unique challenges to us that we use two different electronic medical records here at Butler right now. We have used Avatar for a number of years for our clinical documentation, and initially, we were using just the clinical documentation, and our orders, physician orders, and the medication record were on paper. A couple of years ago, we were part of a system. The rest of the system was using Cerner, so we implemented Cerner for CPOE and the electronic medication administration record. So physicians and nurses are using two records every day. Which complicated our implementation of this because the medication list and any tests or procedures that were done are in Cerner, and everything else comes out of Avatar. So it's sort of everything has to be done twice when we're preparing things for the patient for discharge. The piece of it that comes out of Cerner, the piece of it that comes out of Avatar, and unfortunately at this moment, the two don't speak to each other. So it's double sort of the documentation that needs to be done on some level. So we dealt with that. Oops, excuse me. Jumped the gun there. And so we began working, figuring out how we were going to do this. Certainly we did a lot. We collaborated with our IT folks, with our clinical informatics folks, certainly groups of nurses, groups of physicians, social service, and our health information management staff were all involved in the implementation of this measure because it truly affected everyone across the board. So on our EMR, it required some revision in Avatar, again, which is our clinical documentation record. So we had to do some revisions to our discharge summary. We had to revise our aftercare instructions to make sure that we included all of the measure elements, because again, not all of them were in there. And then we had to actually create a new home medication list through Cerner that included all of the different, the meds that we're going to continue, the new meds, the meds that we're going to stop, and then any of our lab and test results. So it took, as I'm sure all of you know, it took us months to get through that. And to be honest, we're still having some struggles with this along the way. We've done a fair amount of training with our clinical staff, with our physicians, with our nurses, and social services, to let them know what information we need to have them put in the record, and then also where they can find that information and where they can put that information to make sure it moves itself into the reports at the time of discharge. And then we had to work with our health information management staff to work with them to make sure that record got out within 24 hours. Under IPFQR, we were under the five-day rule for a long time, and so we had that down pat. But the move to get things out in 24 hours required a fair amount of revision to the staffing down there, to their workload down there, because it's 24 hours a day, 7 days a week, so it's 24 hours. It includes weekends, it includes holidays. We don't have a lot of discharges over the weekends, but we do have some, and we need to make sure we get that information out when we do. So that they were able to successfully do that, and they're actually getting information out now in the high 80% range within 24 hours, which is, I think, pretty remarkable. I think our biggest struggles right now have to do with our electronic medical record. We've done all of the revisions that need to be done. Unfortunately, we're having some trouble still getting some of those elements into our discharge, the transmission record itself that's going home with the patient and being transmitted to the next level of care. And so we're not, obviously our numbers are not very good at the moment. So I'd like to, if we could, I'd really like to talk a little bit about, hear from other folks actually, questions or comments about how things went with them and how it went with you, and, we can learn from each other and try to make this go smoothly.
Thanks, Dr. Alexander. If you would like to ask a question or talk over the phone, you can press #6 to unmute your line, or please feel free to write in the chat box as well. Just make sure you're signing up to all participants. Again, that's #6 for your phone.
Hi, this is Erica in Bridgeport, Connecticut at St. Vincent's Medical Center. Can everybody hear me?
Yep.
We can.
Okay. I'm on the Cerner, the one chart, the standard model that is fairly new. I don't know that there's only us and Via Christi on it, and it's a standard model. And we struggle with getting all these elements into the electronic standard model. But I'm not sure why, because it's regulatory, so we just struggle with the new Cerner model and getting stuff pushed through at the Ascension level to meet regulatory requirements.
Yeah, certainly we've struggled with that as well. I mean, it's, from my perspective, you're right, it's regulatory. It's not like we have a choice of whether.
Right.
No, it seems to me that it's not like Cerner is a tiny program that very few hospitals are using. You would think that there would be some push on that level to get this in there.
Yeah, and we actually, in order to meet all the 11 elements, we have to print out 2 different copies. We have to print out the patient clinical summary and the inpatient clinical summary and give both to the patient and the provider, because we can't pull all the data elements into one or the other. So we have a big challenge with the new Cerner one chart model.
I'm not feeling so bad about having to pull 2 reports at this point if it's happening with Cerner as well.
Yeah.
It's frustrating.
It is
frustrating. How are you doing now? I mean, are you
We're 0% compliant only because we have a couple other things that aren't being completed on the transition record. Currently, having the metabolic panel on there with the HDL and LDL, we have to make more specifications on that to actually meet the requirements. So I don't think we're going to be making any compliance for another couple months down the road. Unfortunately, and we fall out a lot of the times with the having the duration on all the medications because there's a lot of defaulting that goes on in the new one chart, and it's not very intuitive. Anything that's a new prescription, they have to fill in the duration, but for meds they came in on, it's not a required field, and there's nothing for them to remember to do if there's no pop-up or anything. So we fall out on meds that the patients come in on because on discharge there's nothing that prompts the physician to put the duration.
Right. So we did have them put that statement in saying that they should just take them until they're told to stop. It's sort of a blanket. Yeah, one of the quality net calls, they did say that was acceptable. So we have managed to do that. But like you, certainly we are at 0% as well because it's just a matter of getting everything where it needs to be. It's a very frustrating process.
Dr. Alexander, it looks like we have a question in chat from Matt Doyle. We have had some pushback from our providers about including the reason for inpatient admissions since it cannot be a simple diagnosis. Did you encounter the same thing, and how did you address it?
So we did encounter that, and so what we've done is, we tried to look at different areas of the child where we could pull some information. Quite frankly, we tried to look at the formulation, we tried to look at the initial psych eval that was done, but from physician to physician, from practitioner to practitioner, we didn't always want to share to be honest, what was written there with the patient at discharge. So we've asked the physician, so this was sort of a workaround at the moment. Every physician does, every inpatient attending does an attending assessment that first day that they're in. And so we've asked them on that in the first paragraph of that assessment, we asked them to write a brief sentence about the reason for hospitalization. And we're actually pulling that, and this is an avatar, so we're actually pulling that into that one paragraph into the discharge summary. So far, it seems to be working fairly well.
Wonderful. And it looks like we have about 3 questions in the question and answer section of the webinar. Lori asks, what if a patient comes in on no meds and is discharged on no meds?
You do have to document that in the discharge record. You need to say at the very least that there were no meds on admission or discharge.
Okay, great. And Suzanne asks, what elements are you still struggling on?
So, to be honest, I think our biggest problem right now is I think we have our elements there. Where our IT folks are struggling getting the reports done to get things moved into Avatar. So it's primarily that advanced directive measure, the advanced directive element. I think is probably one of the most difficult ones we're having trouble with. The rest of them, we have the information there. We've always had trouble capturing advanced directives, to be honest, and I think between that and the very specific language about them not having an advanced directive, that's probably the one that's giving us the biggest trouble. And then we haven't always put in, major tests and procedures in the patient information that we've handed out. So getting all of that sort of in there with something that's easy enough for the patient to understand has been a struggle for us as well.
Okay, great. One more from Patricia. If the provider is in the same system and is able to use electronic record, besides documenting this is the record, how do you meet the need to notify the provider's office that the patient had a recent admission?
So we don't have a lot of outpatient providers here. Primarily, most of our patients go from inpatient to partial hospital program, and our social service clinicians actually handle that before the patient's discharged. They actually set up that first encounter date for them before they leave.
Okay, great. And then it looks like Lori has a follow-up question from when a patient comes in on no meds and is discharged. She said, checking to make sure does not have to be a med list that states no meds, or can this be in a discharge summary?
I'm not entirely sure of the answer to that. Practically speaking, it seems silly to have a med list with nothing on it. I would imagine that as long as you're documenting somewhere that there are no medications, you would meet the measure.
Lori, if you would like to ask Dr. Alexander any more specific questions, you can press #6 to unmute your phone line. I'm not sure if that was sufficient for you. But again, if you'd like to follow up over the phone line, it's #6.
I'm actually all set. This is Lori. We were kind of struggling with that, if it needed to be specifically in the transition record or documented on a med list, no meds, because that's been a challenge. It doesn't happen a lot, but it happens occasionally.
Yeah, I mean, I think it tends to happen. We have a small adolescent unit. It tends to happen with them more than anyone else, I think. And so the way our record works is when there are no meds, there really is no med list to print out, so we would just document somewhere in that transition record that there were no medications.
Thank you.
A couple more questions in chat, Dr. Alexander. One from Suzanne. Knowing all these measures are captured on the patient discharge paperwork, has there been any negative feedback from patient and or family regarding all this detailed information?
Not the information specifically. I think it's the number of pages that end up printing out. I think one of the things we found is as you know, with the new med list, we also include, you have to include, information about the medication. So in Cerner, we print out the patient education information about the meds, and we're doing that with the new meds primarily that the patient's on. That can amount to a number of pages. We've had some of these things print out at, 30-plus pages. So I think it's not so much they've been actually happy with the information they're getting. They're not so happy with the amount of paper that comes along with that.
Okay. Looks like we have one more question here. It's a little long, so bear with me. But Barbara asks, our hospital uses Epic. The patient is given the AVS after visit summary, while the next level of care will receive a report that includes all 11 measures are pulled in. Both forms are the same. They communicate with each other. The only issue we are having is if one or the other is printed before all discharge info is documented. Did you get that?
I did. So that's, that's a problem. We've had that problem even in with us in Avatar. I think it actually just came up the other day. We had the information was the patient was discharged. It was like at 12:30 in the afternoon. The secretary printed out all of the paperwork, and the aftercare instruction listed the appointment the patient was scheduled for. The patient didn't leave for a couple of hours, and in the meantime, the patient had again talked to the social worker, and a new plan was made for aftercare. The patient was going to actually go, instead of going to see an outpatient provider, was going to go to one of our partial hospital programs. The social worker documented that in the record, but unfortunately, no one knew that it had changed, and the patient ended up going home with partial information. And that ended up getting sent off to the next level provider. It was caught later, and we managed to get everything straightened out. But yeah, we were trying to figure out a good way to communicate that information on the inpatient units to make sure all of that information goes. Does that answer your question?
It's Barbara. Yes, it did. Wasn't really a question. It was just indicating that within Epic we were able to provide two forms, one for the patient that goes home, the AVS, and the other for the providers. And they both talk to each other, which is really nice. So.
Very nice.
Just another quick question. Will there be a chance for like an email distribution list for the attendees so that we can touch base with each other and ask some questions? And those who wish not to participate can opt out of something like that?
This is Olivia. That would probably be a question for Jean.
Okay.
Jean, are you on the line?
I am. Absolutely. We'll pull together all of the attendees. I know in Massachusetts, at least, we do have an inpatient an IPF listserv along with the acute care. So I certainly have no problem pulling that together. And then, to your point, Barbara, we can have people that want to opt out can let me know.
Thank you very much.
You're very welcome.
Looks like we have one more question from Kathy, Dr. Alexander. How did you determine what are the major tests and procedures that need to be resulted and documented in the discharge records for the patient?
So, that's a good question. We don't do a lot of tests here. I mean, it's primarily blood work. So we pretty much include most of the labs. The only time patients really have any other tests, x-rays, things like that, is if they have a medical problem or medical issue that comes up while they're here and we have to send them out for some kind of evaluation and treatment. So certainly anything that was associated with that would be sent along. And the only, they may have, if they have ECT, that would be something we would put in there. But really, there weren't that many to begin with, so we're pretty much including everything.
Okay, great. Another question from Joanna. Has anyone had a problem with the psychiatric advanced directives and if they are recognized in their state?
Well, they're not recognized. Well, they're not in Rhode Island that I'm aware of yet. I mean, you can.
Not in New Hampshire either. This is Megan. We have the same problem. We don't have advanced psychiatric directives. Nobody's familiar with them. Nobody uses them.
Right.
Joanna, I didn't know if you wanted to elaborate at all. If so, you can press #6 on your phone. If not, that's fine too.
Anna? Hello?
Yes, we can hear you.
Okay. We're having an issue with, we actually got a hold of our state attorney general, and we can't really find that it's in the statutes, the Connecticut statutes, and he's not really giving us a straightforward answer on it, so we're kind of up in the air at this point with that particular element. So I just was asking if anybody else was having that issue.
We asked if they have advanced directives. So even the medical advanced directives, then we'll...
Yeah, we do that already. So I know in one of the question and answer webinars on the quality reporting site, there was something about if your state doesn't recognize them, you're not obligated to, you can just, I guess, have it documented in the record that, that it's just not recognized. Because actually you would go through the same thing with a probate and all that if they don't have them. Just like the advanced directives, if they don't have that, the medical advanced directive. So that was my question. I was just wondering if anyone else had an issue with that. It sounds like Rhode Island and New Hampshire are pretty straightforward. They know that, they're not recognized in those states. We're kind of up in the air at this point. Still waiting for a definitive answer.
Paula Duffy did put in chat, in Rhode Island, psychiatric advanced directives are not allowable. We added a statement on our DC paperwork that stated Rhode Island cannot execute psychiatric advanced directives. We do have to comply with the medical advanced care plan. So, yeah.
Okay. Thank you. That's so if we have that issue, we can just put it right in there like you did. Thank you very much.
Charlie, have you noticed a delay in your discharge process where you can't get patients out as quickly as you did previously? Is that really causing any type of backlog for you?
It doesn't seem to have. We're actually, have a little initiative going on to try to get patients out earlier in the day. But, to be honest with you, it's been such a chronic problem with us getting people out in a timely manner in the morning that it's hard to say that this really had much of an impact.
I have a question about timely transmission. Hello? Well, patients refuse to have the record faxed to anyone. So what do, I have to say that no, it's not transmitted. Is there any, they don't even offer a solution to say, there isn't even an option to say the patient has refused to allow the information to be transmitted.
No, there isn't. It's actually, you fail the measure if that happens.
Right. So, has anybody run into this? Patients do have that option of saying they don't want it sent on.
We run into it fairly regularly, especially on our substance abuse unit. They just don't.
Right.
So this is Lori. In that case, we've run into that as well. In psychiatry, you need to have a separate release to be able to send out that sensitive information. I don't see why you couldn't put that the patient refused and you referred them to the ER if they needed to seek immediate care, and I would think that would meet the measure.
This is a nightmare.
Yeah, I don't know if ER would meet the measure. I'd have to...
I don't know that would.
So we've been advised by our legal department that actually that falls under the HIPAA continuum of care. And so you have to notify the patient, especially with the new HIPAA regulations that were enacted in 2012 or 2013, I guess, that you have to notify the patient that you're transmitting the information, but for continuum of care, as long as it's to the next level provider, that it fits under that continuum of care part of the HIPAA regulation.
I would want to see that,
per state, that wouldn't be a HIPAA violation. Because I know in any of the consent forms, it does say specifically that you have to consent for release of psychiatric information separately.
And then any substance use information separate from that.
Yes. Yeah, I was kind of including that in the bundle.
Yeah. Part of our problem with the substance use is that, so many of our patients are dual diagnosis that it's difficult to separate that out in the record.
Separate from, oh my God.
Please remember, guys, if you press pound 6 to unmute your phone line, we can hear you. It doesn't remute.
Any other questions? Comments?
Dr. Alexandre, do you have anything else you'd like to add before we wrap up today? Oh, wait. Oh, no, it looks like I'm... Oh, it looks like we do have another question in chat. I'm sorry. Suzanne, it might not be a question. Back to the psychiatric advance directives, one chart requires that the behavioral health patients are asked if they have psychiatric advance directives, so we are able to capture this information on admission. Looks like that's more of a comment.
That's when we capture our, we ask them about the advance directives, general advance directives, and we do capture that on admission as well. We would also capture if there was a surrogate decision made from someone had a guardian or something like that. We would capture that as well.
Thanks, Dr. Alexandre. Sorry to interrupt you before. Did you have anything else you'd like to add?
No, I don't think so.
Anyone else? Last chance for questions, comments?
I'd just like to thank people. It's good to hear that, it's always good to hear that you're not alone going through some of these things and implementing these. What seems like a fairly straightforward measure is much more complicated once you start working on it. So it's good to hear from other people going through it.
Thanks a lot, Dr. Alexandre. I just wanted to thank Dr. Alexandre for a great discussion. I just had a few last-minute announcements before we end today. So when you close out of this webinar, the evaluation will automatically pop up on your computer. If you could please fill that out, we would greatly appreciate it. If you don't have time to fill out the eval right now, or you're currently sharing a computer with someone else, you'll receive an email tomorrow morning with a link to the evaluation as well as a link to the event page on our website. The PowerPoint presentation was in your Day of Details email, and it's posted on our website. And within the next few business days, a recording and a transcript of the webinar will also be added. So thanks again to everyone, and I hope everyone has a great day. Thanks, Dr. Alexandre.